Hello, everybody, and welcome to the 7th Annual Women's Heart Symposium. It's a beautiful day, kind of cool for North Carolina, but we're so glad that you decided to join us. This is the 7th Annual. We did it in person last year and trying to get it together by Zoom this year. Just a few housekeeping things. If you wanted to ask some questions of the speakers, please use the Q&A box at the bottom of the screen. And if you and we'll try to answer as many of them as we can at the end. I'm very happy to have Dr. Thelsa Weickert and Dr. Lisa Rose Jones, both co-workers and peers of mine in the Division of Cardiology, who I've worked with for, I'm not going to say how many years because that will age us all out. But they are here today to help share their knowledge of women's heart disease and women's issues. And hopefully we'll do that for many years to come. So I'm just going to go ahead and jump in and let Lisa get started. Lisa.
Thank you, Dr. Miller, for that introduction, and thanks for having me again. I always look forward to these symposiums and get-togethers. I'm going to go ahead and share my screen, so bear with me here for just a second. Wait for sharing privileges.
It's like with Logan and Max, like sharing and Kate.
Yes, there we go. All right. Can everyone see me? I'll look at Dr. Weickert since I can see her face. Are you able to see my screen? All right, great. So I am Lisa Rose Jones. I am an advanced heart failure and transplant cardiologist, and I also treat pulmonary hypertension here at the University of North Carolina. And I'm delighted that you all are taking time to invest in yourself and your heart health. I'm excited today to talk to you about heart failure in women, a topic that is very near and dear to me. Let me tell you a little bit about why that is. So this is my baby girl that we just introduced into our family during the pandemic. And here she is, baby Kate, in her cute little lead that one of my cath lab nurses fixed for me, her scrubs and her lead and her scrub cap that match mine. And it is through advances in medication and management that this other person, who happens to be my mother, is able to celebrate and enjoy her. My mom at a very young age was diagnosed with coronary artery disease after struggling with breathlessness for a couple of years that kept being put off as other issues until an astute physician finally figured that out. And she also suffers from a wee bit of heart failure. And I'm really lucky that one of the very best cardiologists in the world and one of my very close friends, who you're going to hear from in just a bit, Dr. Weickert, looks after her. And so she's able to very much continue enjoying her grandchildren, including the newest one here, baby Kate. So cardiovascular disease is a large term that encompasses quite a few different disorders, but basically at the heart of it is that it's the disease that affects the circulatory system, and the circulatory system includes both our heart and our blood vessels. Heart disease, kind of lumped as one, is the #1 killer of women. And in fact, it outweighs the following several conditions, even when they're all put together, including things like cancers and chronic lung disorders, etc. And so it's really an important topic for us to be here discussing today. A couple of the different examples of cardiovascular disease, some of which you have heard from previously and will continue to hear more about, include things like high blood pressure or systemic hypertension, congenital heart defects, meaning our heart, the way that we're born, may have abnormal hookups. There may be holes in the heart. There may be abnormal valves that we're born with. Peripheral vascular disease is another one that includes narrowing from plaque buildup of the arteries that supply our distal muscles, particularly in the legs, the calves, and the buttocks and the back of the legs. Stroke and transient ischemic attack include disorders that affect the blood vessels that carry blood to our brain. and can lead to devastating consequences. Congestive heart failure or weakness or inability of the heart to meet the demands of the body. And last but certainly not least is coronary heart disease or atherosclerotic plaque buildup, narrowing of the arteries that supply our heart. So I'm going to spend the next few minutes talking to you a little bit more in depth about congestive heart failure, which has long been a very scary term when we hear it, and talk a little bit about where we are and where we intend to go with that. So one of the questions that I get so much about is, hey, doctor, I was told I have this number of my heart, this percentage, and I don't exactly understand it. Well, when we talk about congestive heart failure, one of those numbers that you will tend to hear physicians bring up in their conversations with you and talk to you quite a bit about is something called the ejection fraction. So it really is worth taking a few moments to review what that is. The ejection fraction basically is a measurement of how much blood is being pumped out of the left ventricle of the heart. You will recall that the heart has 4 chambers. It has 2 top chambers of the heart, the atria, and 2 bottom chambers of the heart, the ventricle. The left ventricle is the thickest, most muscular structure of the heart. It is the chamber that directly pumps blood into the aorta that then sends oxygenated blood throughout our whole body for our organs to receive. And so again, the ejection fraction, what we are typically referring to is that of the left ventricle. And again, it compares the amount of blood in the heart to the amount of blood pumped out. Now, normally, most of the time, what we consider a normal ejection fraction in most individuals is going to be somewhere along the lines of 55 to 60, 65%. So you'll notice it's not 100. We don't completely empty out our left ventricular chamber. So 55 to 60 or so is normal. And when we start going down from there to less than 55% or so, that's when we start to talk about the ejection fraction being reduced. So congestive heart failure really comes in 2 flavors. And the first flavor is systolic heart failure. And this is probably the one that's most easily understood, but also the one that we tend to talk about more so. That means with systolic heart failure, it has another term called heart failure with reduced ejection fraction, or HFrEF. And it can go by terminology such as cardiomyopathy as well. And many times when people refer to CHF, particularly in the past, this was the heart failure that they were referring to. And it simply means that there's been some event that has caused the heart to weaken, and it doesn't contract with enough force to push out oxygen-rich blood to be pumped throughout the body at the amount that it needs. Because the heart is weak, it also causes some more blood to accumulate in that left ventricle, and it leads to a rise in pressure that then backs up from the heart into the lungs, of course, causing breathlessness, which is a hallmark symptom. So again, systolic heart failure means there is a reduction in that ejection fraction. The heart is weak and the pumping function has fallen. Another type of heart failure that sometimes we like to refer to it as the new kid on the block. It is a disease entity that we are just starting to understand a little bit better, but is one that does also affect women quite a bit. And that's something called diastolic heart failure. It goes by the term heart failure with preserved ejection fraction, or as many people like to refer to it, HFpEF, which is fun to say. HFpEF, or diastolic heart failure, means that the heart is actually pumping just fine. The contractile function is normal. The ejection fraction, therefore, is your typical 55 to 60%. But what is different about the heart is that that left ventricle doesn't relax as well. It's very, very stiff. And that's a common phenomena that we can see, particularly in females as we age. The problem with this is, although the contractile, the pumping function works, the impaired stiffness results in a higher pressure in that ventricle for any given volume that is there. And that higher pressure is going to back up via the path of least resistance, and it's going to back up into the lungs, which are before the left side of the heart. And so this too can cause quite significant breathlessness. So those are our two flavors of congestive heart failure. Just to give you a little bit of an example, how we usually evaluate for heart failure is something called an echocardiogram or an ultrasound of the heart. Here on your screen to the left, just to give you an idea and a little primer for being a cardiologist, this is a normal ejection fraction. So here we see that left ventricle. And again, this is a squeeze that's happening at about 55% or so. Okay, and then here on the right side of your screen, what you'll see is systolic heart failure or heart failure with reduced ejection fraction. And this is just an example of the ejection fraction of the contractile performance being significantly decreased. So normal here on the left, everything moving in nice. And then here on the right, the left ventricle really struggling, and we don't see a lot of movement or contraction in. So both of these, both systolic heart failure and diastolic heart failure, are truly neurohormonal processes at their core. I'm going to spend most of my time referring to systolic heart failure, and because the diastolic heart failure, or the issues with impaired relaxation, is a little bit of complicated physiology that's really beyond the scope of the talk today. So I'm going to focus on systolic heart failure. So with that, with a reduced pumping function, our kidneys get that sense. They get a drop in that blood flow. And what happens when those kidneys sense a drop in the blood flow, as well as the brain, is they send lots of feedback out to the body. And what happens is the kidneys release a hormone called renin that gets revved up and calls some of its friends along. And those hormones cause vasoconstriction or clamping down. They also cause water retention and fluid buildup, and they promote fibrosis of the heart or collagen deposition. The brain is also signaled that there is an issue that's occurring, and it stimulates our sympathetic nervous system, or our fight or flight, our adrenaline releasing system. And that too causes an increase in heart rate, puts more strain on the heart, causes again more clamping down or vasoconstriction of our arterial bed, fluid and water retention, fibrosis. And that leads to our symptoms that we experience with heart failure, i.e. swelling, fluid accumulating in our legs, our belly, shortness of breath, those sorts of things. So this truly is a neurohormonal process at its core. Now, causes of heart failure with reduced ejection fraction, a couple of take-home points is that women with heart failure are more likely than men to have high blood pressure, leading to congestive heart failure, valvular disease, which my colleague Dr. Weickert is going to talk about here in just a bit, and diabetes. On the contrary, though, we are less likely than males to have heart failure due to heart blockages or heart attacks, ischemic cardiomyopathy. Although we're less likely, there are still many women who do have this as a cause. And so it's important that we remember in women that they can present with atypical symptoms. Just as I mentioned earlier about my mom, she never really had the classic angina, chest pressure, chest tightness. It was more breathlessness and losing her breath when she tried to do the things that she enjoyed. Despite the incidence being lower than men, it's still very, very important that when we diagnose a patient with reduced pumping function of their heart, that they are evaluated for blockages in the arteries, because those are something that we can help improve and fix. Some unique causes of heart failure with reduced ejection fraction in women include the fact that many of our breast cancer treatments are with very good therapies like adriamycin, but those are associated with the development of heart failure and can be cardiotoxic at increasing doses. The other unique cause of heart failure in women is something called peripartum cardiomyopathy. And this is the development of heart failure, typically in the last trimester of pregnancy and following the months after delivery. So we still don't completely understand the culprit of this, and there's several different theories that exist as to why that is. As I mentioned earlier, when we talked a little bit about the underlying pathology that was occurring with heart failure and the neurohormones that were being revved up, again, what they lead to are symptoms including shortness of breath, swelling of the legs and feet, fatigue, really lack of energy and lassitude, difficulty sleeping at night. Usually the breath is being cut off. Your belly can be swollen. You can kind of fill up early when you're eating, cough with frothy sputum, weight gain that suddenly fluctuates, urinating more at night or in the early hours of the morning, and as the disease progresses, confusion and memory impairment. This is certainly a disease worth talking about because it affects over 3 million women here in just the United States. Women do typically develop congestive heart failure at an age older than their male counterparts. And despite the fact that women account for nearly half of all hospital admissions for heart failure, we've really done a very lousy job at creating equitability and studying heart failure in women specifically. In fact, so much so, here are some of the landmark trials that looked at medications that have now been shown to lengthen life in patients diagnosed with heart failure. And as you can see, the overall total percentage is 23% in the Merit Heart Failure Study that looked at the use of metoprolol for the treatment. Solvid, which was a study of ACE inhibitors, 20%, 27% in Rails, which looked at the use of spironolactone. And one of the more recent studies, Paradigm, which looked at the use of the drug Entresto, which you may have seen commercials on, had an abysmal 21%. So my job as a heart failure cardiologist here at UNC is definitely to encourage my female patients who are diagnosed with heart failure when we have clinical trials open to become involved with them. We know that women are different in their biology and how they present with so many different heart issues and also in their response. And so it's important that we have an equal representation in these studies that are leading to guidelines in how we treat heart failure. So speaking of which, our treatment for heart failure is really aimed at blocking all of those bad players and those hormones that I mentioned that are revved up in this process. And so we have quite a few different drugs that intercept those hormones along this process. Those include things like beta blockers to block the sympathetic nervous system, drugs like ACE inhibitors, angiotensin receptor blockers, the newer drugs like Entresto, which is an angiotensin receptor neprilysin inhibitor. Don't worry, we won't test on the names here later, but all of those medications are used to block these processes. Some of those drugs can also be used to treat high blood pressure. And so it's really important that those medications, if you are diagnosed with heart failure, are not stopped by another provider if they think that you're just on them for high blood pressure, because they are very important in prolonging survival in patients with heart failure. In addition to that, we encourage our patients, because of the fluid and water retention that happens, to limit the sodium in your diet, avoid fast foods and the salty six, things that are notoriously high in salt, like cold cuts, poultry, and that are prepared with sodium. Soups are notorious. Condiments tend to have a lot of high salt content, and those can all promote fluid and water retention. With the right care, heart failure, though, will not stop you from enjoying things that you find that bring you happiness in your life. And in general, women actually do survive longer than men with heart failure. And your prognosis or your outlook for the future with a diagnosis of heart failure really depends on how well that heart muscle is functioning, your symptoms, and how well you respond to and follow your treatment plan. But I will say, in our current era, we have a really great arsenal of medications to treat heart failure and have really changed the longevity and the outlook of patients with heart failure. So with that, I'll stop, and I thank you so much for your attention.
Thanks, Lisa. That was great. And you made it through without even having to go do the TEE. So Thelsa, without any ado, I'll turn it over to you. This is Dr. Weickert.
Thanks, Paula. Lisa, that was fantastic review, and I'm glad you covered some of it that would actually feed into my talk today. So let me just share my screen here for a moment. And Paula, Lisa, could you just confirm you can see my screen?
Yes, looks good.
Awesome. Thanks, everybody. And again, as Lisa said, I do want to echo, both of us are very excited to be part of the symposium. I think we've been part of it since we were both fellows in this program. Please don't ask how many years ago. Well, Lisa has a little bit of an advantage in that regard over me, but this has been a real endeavor of love by Paula over the years, and you guys have been supporting this through the years, which has been really terrific. So I will spend some time today talking about valvular heart disease, and I think it's a good segue from Dr. Rose-Jones' topic. It's one of those topics that honestly I could spend hours and hours talking, and I still probably wouldn't be able to cover everything. So what I thought was kind of touch upon some of the highlights and some of the newer innovations that are currently available, especially here at UNC. So, and then happy to take questions. I'm sure you have a few. So just as a recap, the best way I kind of explain the various parts of the heart to my patients, I try and tell them there's a structural components of the heart, how your actual heart chambers are made of, and then the things that separate these various chambers of the heart are these heart valves. And then you have the plumbing, which is mostly the coronary arteries or the blood flow to the heart muscle. And then you have the electrical circuitry, which is what determines the rhythm that your heart is in, if it's regular or irregular and things like that. So Lisa kind of touched upon things where, this, like she said, in the systolic heart failure, where the pumping function of the heart's not quite right. And some of these kind of coexist. So what I'm focusing on today is also related to the structure of the heart, but slightly different topic, which is kind of focusing on the valves. And as you can see here, most of our hearts, we have 4 valves that kind of direct the blood flow within our heart. So you've got this 4 chambers of the heart: the right upper chamber, the right atrium, the right lower chamber, the right ventricle, and similarly on the left side, the left atrium and the left ventricle. The right side of the heart is where the blood comes in from all the veins of your body, and this is now then pumped up into your lungs. And so you have these 2 valves on the right side, the tricuspid and the pulmonary valves, after which it kind of goes through the right heart and then goes up into the lungs. Gets all its nice oxygen in the lungs, and then it comes down into the left side of the heart. And we have 2 valves on the left side, the mitral and the aortic valve. The aortic valve being the final valve in the heart, after which the blood is pumped. The nice oxygenated blood is pumped to the rest of the aorta. Now, this may be very basic for most of you, but I thought it would be a good place to at least start. So when we talk about heart valve disease, in general, there are 2 big components of valve issues that we're dealing with. One is narrowing of a certain valve, which is when the valve doesn't open quite right. So you can imagine when the blood's supposed to go in a certain direction, the valve is supposed to open and the door is supposed to let that blood pass through, and when it doesn't really work as well, and that opening is narrowed over time, it can restrict the blood flow. This is what we call valvular stenosis. You can have the opposite problem, which is when the valve's closing, it doesn't close quite correctly, and there's a gap. And because of this gap, instead of the blood kind of moving on to the next chamber of the heart, some of the blood goes back into the previous chamber or leaks backwards in the heart. And this is what we call a leaky valve, or technically regurgitation. You may have heard of a terminology called prolapse, which essentially just means, actually, let me move the screen. So here in prolapse, you can see sometimes one of the leaflets kind of slips out of place a little bit. It doesn't quite come together and line up as correctly. And so that can cause leakiness of the valve too, which is what we call prolapse, and a common area valve we see it in is mitral valve prolapse. Very common condition, about 1 to 2% of us have it. So causes in general, when we talk about heart valve disease, some of the heart valve issues can be congenital, which is we're just born with it. A classic example being in the aortic valve, for example. The vast majority of us, we have 3 leaflets that make up the aortic valve, but about 2% of the population, we're born with 2 leaflets instead of 3. So when that happens, usually by the time you get to about 40 to 60 years of age, you often are dealing with some issues such as either narrowing of that valve or leakiness of the valve. So those are examples of congenital heart valve disease. There can be others that we're all born with just the normal valves, but over time, for example, as we age, you can have some calcium deposition on the valves and lead to degeneration of the valve. There can be infectious issues such as rheumatic heart disease. This is related to strep infections in childhood that later on in life can manifest as rheumatic heart disease. As Lisa mentioned, heart failure, where you have a very enlarged heart. So, the valve itself is okay, but when your heart is enlarged, the 2 sides of the door just don't come together as well and can lead to a gap and can lead to valvular issues like that. And then more and more, unfortunately, because of the epidemic of patients sometimes using IV drugs, we can see a lot of infections that can affect the heart valves, and this is something we call infective endocarditis, and that can cause damage of the valve and can cause to leakiness of the valve and things like that. So how do we pick up on issues with the heart valve? And the most common place, the first sign is often when your doctor listens to you in the clinic and they can hear what's called a heart murmur, which just means that the blood, instead of flowing very smoothly, there's something causing turbulence to that blood flow. And that turbulence is what we often hear on auscultation as a murmur. Of course, the best test we have to look for any sort of valvular issues is an ultrasound of the heart, which is an echocardiogram. And this not only can confirm the diagnosis, but it also tells us what the severity of the valve condition is. Is it just a mild leak, which often 25% of the people walk around with mild leaks of the valve, and it's not usually something that has a lot of clinical impact. But if there is a severe leak of a valve or narrowing of the valve, that could be something that you would have to discuss, what would be the right time to fix something like that. So because it is a short talk, I thought I would kind of focus on a couple of common valve conditions and what we do for this. One of the most common valvular issues that we see, especially with age, is aortic stenosis. As you recall, the aortic valve is that last valve in your heart after which the blood is then pumped to the rest of your body. And a normal aortic valve, you have these 3 valve leaflets. You have this 1, 2, 3 valve leaflets. But often as we all age, you can tend to have calcium deposition on the valve, which kind of impedes the way the valve leaflets open up. And so this can be either from calcification of the valve or fibrosis of the valve, and it kind of limits the opening of the valve, and it causes it to narrow over time. And this is what we call calcific aortic stenosis. This is an example of a bicuspid valve, which is a person who was born with just 2 leaflets, as you can tell, rather than 3. And over time, usually, like I said, in the 4th to 6th decades of life, we see a lot of calcification on the valve, and these valves can tend to wear off sooner than somebody born with 3 leaflets. So that's an example of a bicuspid. This last one isn't as common in America as much as in countries like India and places like Central America, but this is an example of a rheumatic heart valve where you can see that we call these the valvular commissures, which is the kind of the tips over here or the leaflet edges, they tend to fuse, and then over time it causes narrowing of the valve. And so these are all very common reasons for somebody to develop aortic stenosis. And for the vast majority of folks, the patients even who have close to severe aortic stenosis often can be asymptomatic for a very, very long time. And maybe somebody that, you have a murmur and the doctor's picked up on it, but they stay without many symptoms. However, as you can see, if you start having symptoms, and the big ones being chest pain, especially exertional chest pain, which is angina, classic for angina, dizziness or passing out spells, or you start having heart failure symptoms like what Dr. Rose Jones alluded to. Once you start having symptoms, you really have a precipitous decline in your survival right after that. And so it's very crucial for us to pick up patients just before, ideally before the symptoms develop, somewhere around here in the curve, and then try and intervene on the valve right about this time. So this is, again, an area of lots of research that's ongoing at this time of what's the perfect time to intervene on these patients. Aortic stenosis is not uncommon. about 16 plus million patients in the US over the age of 65, as you can see, have aortic stenosis, with the prevalence being right around 7%. And as we have, as our population ages and we have people living well into their 80s and 90s and even hundreds, you can imagine this is getting much more prevalent over time. It does tend to affect men more than women, and some of it has to do with a little higher calcification burden in men, but we do see this in women too, so it is not exclusive. It is kind of sobering when you think of a 5-year survival once you have severe inoperable aortic stenosis. Historically, you can see the survival is almost worse than even lung cancer and some of the other cancers that everybody sees in the press, and you worry about survival. But if you have inoperable severe aortic stenosis, your survival is like less than around 3% at 5 years. So this is a very serious condition once you develop it, once you get to the severe stage. And historically, there wasn't many easy options to fix this problem. Really, the standard of care was we had to replace the heart valve, and the only way we could replace it was doing a full sternotomy, which is opening the chest and doing a full open heart surgery and replacing the old diseased valve with one of the newer valves, either a tissue valve or a mechanical valve. Both has its own advantages and disadvantages. Tissue valves, the advantage, the big one, is that you don't need to be on blood thinners. The common one, actually the only one we can use is warfarin in today's day and age. And as if you guys or a few of you, if you're on warfarin, you realize it's a bit of a hassle. You have to often get your blood levels checked like a couple of times a week, and it can be quite challenging, especially you have to watch your diet and things like that. But the biologic valves, you don't need to be on it, but have a shorter durability. Often they last only about 8 to 10 years, and sometimes even less if the patient is younger. Mechanicals do last lifelong, theoretically, but at the same time, you have the downside of having to be on a blood thinner with it. So I truly believe one of the best inventions in modern day medicine that has come about in the last decade or so has been the invention of this TAVR procedure, which is a transcatheter aortic valve replacement. So this has really changed this arena of valve, treating this valve condition in the past few years. And obviously UNC is a very high volume TAVR center. And this, as you can see, is an animation of, instead of cracking open the chest, we're now able to do this entire valve replacement purely through a transcatheter approach, which means they kind of go in with a wire through the blood vessel in your groin, and then they put this wire across the diseased valve into the heart. Over this wire, they thread this balloon, as you can see, open up this balloon, which is mechanically just kind of disrupt open that valve. And then once they have that valve opened, they then come up with a catheter, which has the new valve mounted on it. And as you can see over here, they thread this over the previous wire, bring it up to the valve. So this right here is the valve, as you can see. And we come up with it, come up to the valve, and then they expand this valve over the wire. And this whole procedure these days, I mean, the folks here at UNC, they've gotten so good at it, usually is less than like an hour and a half to 2 hours. And here you go, you have a new tissue valve placed in the position of the old valve, and then they take out the catheter, and often the patient goes home within a couple of days after the procedure. So I think I'm kind of coming short of my time. So I'll just end by saying, historically, these procedures were reserved for patients who were deemed inoperable based on the early trials, but now more and more we're able to offer this for lower risk individuals who otherwise could have been surgical candidates, but because it's so safe and so easy that we are now starting to do it in lower risk population. We have 2 valves currently approved by the FDA, the Edwards valve and the Medtronic core valve, both of which UNC we are sites for. So depending on your anatomy, that's the kind of valve you get. I will end by saying no story of TAVR valve is complete without mentioning this gentleman. This is Dr. Anderson, who's the gentleman who actually came up with the idea of having a transcatheter valve. He was kind of poo-pooed when he first presented it. Eventually, he kind of went up to his lab and created it out of pig tissue. eventually ended up selling his patent for about $10,000. That Anderson patent is currently in millions of dollars, and which is what, you would think he'd be all annoyed by it. But the fact is his dad actually ended up getting a TAVR valve. So he says, in a way, he's glad it became a full circle and he was able to help his own dad with his discovery. So since I'm out of time, I'll send the rest of the slides out, but I'm happy to take any questions.
Also, you have a little more time if you want to.
Oh, sorry, I thought I was running out of time. Are we going to, how much time do we have?
For a few more minutes, yeah.
Okay, so I'll just touch upon real quick in the mitral arena, which was another valve on the left side. This is a common problem that we see is the leakiness of the mitral valve. And again, as I mentioned, these can be just degenerative that can happen over time or related to rheumatic disease or an infection of the valve, or as Dr. Rose-Jones mentioned, related to a cardiomyopathy where you just have an enlarged heart and the valve doesn't close correctly. It also has tremendous impact on your survival, especially when you have severe mitral regurgitation. As you can see, the survival curves when you compare somebody with mild MR to severe MR. So we really have to kind of intervene on these patients if medication therapy isn't working. So unlike an aortic stenosis, where there really isn't any medical fix to the problem, in mitral regurgitation, often we can do things that can help, and we try very hard to do with medications, a big one being diuretics or water pills to kind of decongest the heart. Optimal blood pressure control is very important. And then often these patients also have concurrent atrial fibrillation, which I believe Dr. Baker went over earlier in the day. And so if you have that, we often have to use blood thinners to help. And again, standard of care used to be either doing some sort of a valve repair with a surgical ring or replacing the valve and putting in a new tissue or a mechanical prosthesis. However, there is now an option of doing what's called a Microclip procedure, which is again another transcatheter procedure, similar, like I showed you, to the TAVR valve, where they come in from a vein in the leg and then they go up into the heart, cross over to the left side of the heart, and we cinch in the two leaflets of the valve together and kind of put a stitch on it or a clip on it. And this is called a Microclip procedure. This has been shown to be durable in trying to really reduce the risk of leak of the valve. So these are some of the newer innovations. There's much more coming in the valve arena, but I'm sure if you have any questions, I'm happy to take them during the Q&A session, but just wanted to give you a little primer on some of the things that are available in today's management of valve disease. So we have a big team here at UNC. These two guys up here are the ones who really lead the team, Dr. Bavali, Dr. Cavender, the interventional cardiologists who do most of the valve procedures here. We also have a big support from our surgical colleagues, Dr. Cardiomesis and Dr. Ikonomides. And then we, including myself, Dr. Hinderleiter and Dr. Sivak, we are the imaging support where we help them with the planning of these procedures and also in the intra-op side. So that's all, and thank you for your attention.
Thank you, Thelsa. That was wonderful. I don't see a lot of questions in the question box, the question and answer. So if anybody has questions, please do send them along. I just wanted to say that everybody that's attending here today, there was a comment that they would like to have the slides. We will be sending out T-shirts and flash drives. The T-shirts will be the 7th annual Heart Symposium, and the flash drive will have all of our slides from today on it, as well as some other information for you to be able to get, see the presentations and go to resources like the Go Red for Women site and the Heart Truth site and some other informational places that you can go. So we don't have to send them out individually, but everybody will get one. And I would like to say thank you to Lisa and Thelsa. And there's a question. Let's see. What's the cause of frequent urination at night and early morning that was mentioned? I don't know which that was, but which one of you that wants to answer that? Thelsa, maybe?
I think Lisa.
Or Lisa? Lisa may not be here.
She
may be doing PEE.
Yeah.
It was Lisa.
Yeah.
So, I mean, frequent urination at night and early morning can be some of the side effects of the medications that you need to use for heart failure. Or it can be, postmenopausally, it can be things that aren't even related to the cardiovascular system.
And I do believe there was one question that was submitted previous to our session today, and it was how has CardioMEMS impacted outcomes in HFpEF?
Again, that would probably be Lisa.
Lisa,
I
okay.
can try and attempt it.
Yeah.
I'm not a heart failure doctor by any chance, but CardioMEMS is a small device that's implanted in one of the branches of the pulmonary artery, which is the part of the blood vessels that supply the lungs. And so it's a little device that's actually implanted. It's a minor outpatient procedure actually that's done, and patients often go home the same day. And the reason this CardioMEMS is good is it's shown, so once they go home, they actually sleep on a pillow that transmits the pressures in the pulmonary arteries on a daily basis. So every night it's transmitted. We actually have one of our nurse coordinators, Carrie Neal, who actually monitors these. So when we see that the pressures are going up, often we can tell that the pressures are going up even before people have symptoms of fluid overload. So when you have a heart failure exacerbation or things that require you to end up in the hospital, is often you're having too much fluid buildup in your lungs, and then you get shortness of breath and the swelling in your legs and other symptoms. Even before the symptoms come on, the CardioMEMS can detect that the pressures are going up and can kind of, when you're monitoring these on a daily basis, you can tell, oh, it's time to go up on your water pills, for example. And so the data for CardioMEMS historically has shown to prevent hospitalizations related to heart failure. So instead of getting in the hospital once you've got so much fluid that you're needing IV medicines to get the fluid off, CardioMEMS, at least the trial data showed, you can help prevent some of these hospitalizations by acting on them early, on the data early from the CardioMEMS, and increasing your water pills as an outpatient. So I don't know if that was exactly the question, but that's my little take on CardioMEMS.
The questioner also just said it was the urination was a mention in the symptom of heart failure, and it could be. It's probably not the first symptom that you would notice with heart failure. Do you agree, Thelsa?
Yeah, I agree. I mean, I think at least much more commonly in my practice, I would say it has, like Paula, as you said, it has to do more with the diuretics that folks are on, or the water pills often people are on. But I can imagine, I mean, if you have a lot of water retention as a part of heart failure, frequent urination as being a part of that, but much more commonly we see it as a part of the diuretics.
Well, thank you, everyone. I'd like to specifically thank Brian and Allison and Barbara Reed Mills, who without them this couldn't have happened, and the other people at the foundation, Samantha and I believe Brittany, all the folks that helped out. It's been amazing getting it together and having all of us be able to do this by Zoom in the days that we can't be together. So I appreciate everybody's help on the program. Hopefully we'll be back in live or some form of hybrid for the 8th annual next February and get things back on schedule. Again, we will be sending out the flash drives and T-shirts. If you didn't sign up with your, there's Lisa. If you didn't sign up with an email address, or we can email you for your address or mail it to you, let us know. Lisa, do you have anything to add?
Sorry, I missed everything, but thanks for being here.
my feeling too. Thanks.
You're
to
great.
Everybody. It's been a wonderful, wonderful seminar. And I hope that the participants have really learned a lot. So I'm going to turn it over to Brian.
Thank you, Dr. Miller. It's been a real pleasure of ours at the foundation to work with Dr. Miller and all the various faculty members who've graciously given of their time to come and present all these wonderful sessions, so that you as attendees can to continue to learn. And thank you for joining on and listening to all this. And if you'd like to learn more about the Women's Heart Program or UNC Cardiology, please feel free to reach out to me with my email, which will be posted on the Zoom here in a minute. And if not, you will be getting a follow-up email early next week, which will have all the PowerPoints that have been presented. It will have links to the recordings. So it's going to just be a wealth of information, just in case you miss anything, you get questions. And if you would like to follow up with one of our cardiologists or one of our presenters on a specific question, please let us know, and we're happy to connect you. That's what we're here for. And if Dr. Miller was gracious in saying that this symposium we helped out. We helped out a little bit, but really and no pun intended, she's the heart of this. She's dedicated her career to this, and we want to make it bigger and better every year. And one way that you can help us do that is by going to the website that you see on this slide right here, and getting engaged and getting involved. We have many people who support the program, and we're very grateful for anything that you can do to help us with that. But I also want to let you know that there will be a survey that will pop up for you. It's very short, takes about a minute or two. Really appreciate any input, feedback that you might have on our session today or any of the previous sessions. And if there's anything of interest to you that you'd like to learn more about in future sessions, whether it's cardiology or anywhere else within UNC Healthcare, please let us know. We'd love to, we want to put together informative and useful sessions. So with that,
Brian,
Paul,
can I
I'll
say
let
one
you,
thing?
yeah, sure.
That we had a question about how you become a volunteer, and to do that, just get in contact with me or Barbara Reed Mills or Brian, and we will put you to work.
Yes. Yeah. I mean, I think the hope is that not only do we do this in this fashion in hybrid here in Chapel Hill, but that we can hopefully eventually move this throughout the state of North Carolina. That will take people and it'll take funds. So we really appreciate that question and your interest.
Our goal is to make UNC Healthcare and UNC Cardiology synonymous with women's healthcare in the state of North Carolina.
Definitely, and I think it is well represented. Well, thank you so much for your time and your interest in joining us today. Thank you to Dr. Rose Jones and Dr. Weickert, and obviously Dr. Miller and all my colleagues who helped put this together. It's my pleasure to close it out. But with that being said, enjoy your afternoon, and we will see you soon.
Thanks, everybody. Bye.
Everybody.